Hi, Iman.
Hi.
Can you hear me okay?
Yes, I was just about to send you an email in case you were having any issues joining, so I'm glad you were able to get into the practice session.
Yeah, and it says I can't show my video because you have stopped it.
Oh, let me, a good thing we,
Did a practice session.
um, let me see if I can,
Let me try that again.
okay, I made you co-host, so maybe,
Okay, there we go. Hi.
great.
Great, thank you.
Yeah, of course.
Of course, now I'm coughing. I apologize. It's the end of the day. Um, all right, so let me practice sharing my screen. I made some changes, so I'll go ahead and use my slide set. Whoops, I want to do that. Hang on a minute. All right. Do you see the CADASIL and caregiving?
Um, I do not. I see that you're sharing your screen, but I don't see
Hmm.
a presentation.
Okay, hold on a minute. Your screen share is loading. Good grief. I've never had that message before.
Yeah, hopefully it just
Okay, let's get this started. Oh, they want me to start the webinar. I don't want to do that. Okay, hold on. Let's share the screen again. Share.
okay, I see it now.
Okay, phew, that was weird.
Awesome.
Okay, so we have, let me just get here and just go through it. How does that look to you?
Yeah, that looks great. I took a look at it before, and I think that addresses a lot of the questions we get. I actually
Okay.
already had some people email me with questions, and
Oh,
so,
great.
yeah, and some of them, and so I'm sure you're aware, but some of the participants or like community members, they might give like a little more like clinically related questions in the Q&A
Uh-huh,
box,
sure.
like more maybe like a little personal, and so usually
Yeah,
the speaker kind of just like rephrases it if they want to answer the question.
yeah,
They're
yeah,
asking like specific clinical advice. They might just like skip over that question.
yeah. I'm used to that. Do you have any of the questions now?
Yes, I have them, and I also inform them that they can input them, but I have them
Good.
ready.
Oh,
I
great.
can pull them up just so you might
Okay.
get a sense. Let's see. Um, So one of these is asking about like the stages of dementia and like the progression of the disease and what functions are affected. Um,
Okay.
One that's a little more, I guess, related to caregiving is how do we better communicate with our loved one? It's difficult to get feedback and they don't talk much, so
Yeah,
it can be
yeah.
difficult to communicate.
And this is for a national audience, right?
Hmm.
Okay. So the stages in communication. Okay.
And then I actually got two questions from separate people about like toileting and incontinence and how can they as caregivers like kind of circumvent that and deal with it so that it's less
Awesome.
messy. I'm not sure if
Yeah.
that's a question that you would want to answer during the
Yeah, sure.
presentation. Okay, great.
Absolutely. Yeah, that's not a problem.
Awesome.
I'm just I have some national resources, and I have the Alzheimer's Association has some classes Let me just see if I can find those now so that I'll have that ready for them.
Yeah, that was actually the next question is what are the best resources we can get to better understand what her behavior might be
Yeah, the
going through.
tough one for CADASIL. Um, let's see, caregiving care options, stages and behaviors. Oh, yeah, there's some classes and whatnot, so I can let them know about that.
Yeah.
Um, yeah,
And in case, like, I guess for CADASIL, and I'm sure you know better than I, but I assume like Alzheimer's and dementia and CADASIL, like at the late stages, it's pretty similar, like incontinence and like struggles with communication and whatnot. So
yeah,
I'm sure
yeah.
giving a general presentation really helps the audience just kind of
Yeah, it's
understand it.
tricky for sure. And I think, CADASIL is obviously, like we've talked, is a vascular dementia, so it
Mhm.
can be really unpredictable. And I think that's
Yeah.
one of the challenges that caregivers may deal with. And yeah, it can be pretty stressful. So we talk about that, and I have some resources for them. So
Great, thank
yeah,
you. Yeah.
sure.
And we had about 95 people register, so
Oh,
it's great. We
fabulous.
usually don't have like that as many who
Yeah,
attend, but it's recorded and then it's posted to
great,
our YouTube page, our website, and then Cure Catasill's website. So people who weren't able to make the meeting can also see it.
great, great, great. And they're from all over the US.
Yes, from all over the
Great,
US. Yeah,
terrific.
and I was thinking, kind of before we let everyone in, I could give like a brief introduction,
Sure,
about the presentation and then on you, and then tell them about the Q&A at the end, and then just let you take over from there.
sure, that's fine. And if you prefer, I can introduce myself. It's up to
Okay,
you.
great.
Um, and how
Maybe
much time?
introduce yourself so that you can kind of go into the your presentation or like
Sure,
go into it, but
yeah,
I can just give the brief consortium introduction in that case.
no problem. And then how long would you like me to leave for Q&A?
Um, that's honestly up to you, depending on how long your presentation is. I wouldn't want you to
Okay,
cut it short. I would say we
okay,
usually have around like 15 to 25 minutes of
yeah,
questions, really depending
yeah,
on how many questions people have.
that
So
sounds good.
anywhere from like a 30 to 45-minute presentation, I
Okay.
can be
And
pretty,
the whole presentation is an hour.
yes.
Great. Okay. Do you want me to start the webinar? I have a little note here that says start webinar.
Yeah, I think we can
Okay, let's do it. And am I saying your name correctly? Is it Iman?
yes.
Okay, thank you. Okay, it looks like we've started.
Great. I think people are now entering from
Yeah,
the meeting room.
I see people are joining us. It's fun to see those numbers tick up.
Mhm. And then maybe you can share your screen, so they
Sure.
have the
They know they're in
presentation.
the right place at the right time. Are you seeing the CADASIL and caregiving?
Yep.
Great, thank you.
Okay. Awesome. Well, in that case, I think we can start as people start to join the presentation. So thank
Mhm.
you everyone for joining the CADASIL Consortium this evening for our webinar on the caregiving experience, journey, and management of the role for caring for loved ones. Our speaker this evening is Dr. Allison Lindauer, who I'll let introduce herself shortly. We will have an opportunity for Q&A at the end of this presentation where you can input any questions you might have into the Q&A box below. And without further ado, I will let Dr. Lindauer take over.
Okay. Hi, everybody. I'm Allison Lindauer. I'm going to stop sharing for a minute just to say hello and welcome you, and thank you for being here this evening. I am going to be presenting today on CADASIL and caregiving. I am a nurse practitioner at the Oregon Alzheimer's Disease Research Center here in Portland, Oregon. I also hold a PhD, and my research focuses on ways to best support caregivers who take care of somebody with dementia. It can be any kind of dementia, whether it's Alzheimer's, vascular, FTD. Um, uh, we try to help all caregivers. So I'll tell you a little bit more about that at the end. So today we'll go ahead and talk a little bit about CADASIL and caregiving. I hope that you will post your questions, because I think that your questions really help me understand what is needed. So I'll make sure we have time for that. I'll go through the presentation and then we'll take your questions. This is my phone number, and this is where I'm at. I'm at the Oregon Alzheimer's Disease Research Center. We're one of 37 Alzheimer's Disease Research Centers around the nation that are funded by the National Institute on Aging. So today I just want to discuss some of the factors that contribute to caregiver stress, and also talk about the importance of caregiver health. And then we'll talk about some strategies to address some of the stress that I hope you'll find helpful. So you know probably better than I do about the CADASIL definition, the fact that it's the most common hereditary cerebral small vessel disease. So the circulation in the brain is affected by CADASIL and the changes in the brain. And these brain changes result in cognition and mood and behavior changes. So wherever the if small strokes or the changes due to CADASIL are in the brain, that's where we likely see the changes. And some of these changes are due to a number of factors, but the changes we see can be thought of into two classes, basically cognitive changes and mood changes. And CADASIL, some of the earlier signs of this disease process are mood changes, and are often kind of the first signs that people bring in. But the cognitive changes are also important, so let's start there. By cognitive changes, we mean changes in executive function. So difficulty making good decisions. Oh, I'm going to back up one page. These changes and the frequency and the types of changes, this is from this article by Chabriat and Lesnick here. So just so you know, if you want to go look at that paper, it's available to you. And these authors note that these are the common changes in CADASIL. So difficulty making good decisions. In my work, I see this quite a bit. So for example, people who are driving when they should probably think about retiring from driving, people spending a lot of money when they probably shouldn't be. And these changes that we see are consistent. All of us make bad decisions once in a while. That's not the problem. The problem is that they consistently make bad decisions. They may have difficulty paying attention. And again, all of us have that. But again, this is consistent and problematic. There may be changes in memory. So as you know, there are different types of memory. There's short-term memory, remembering, what you had for breakfast, or what you need to do this evening. And then there's long-term memory, what happened last year, what happened at Christmas. There's also a type of memory called episodic memory that has to do with important events. So things like marriages and funerals and graduations. Episodic memory tends to last a long time, and loss of the episodic memory is often associated with more late-stage dementia, but we do see it even in moderate stages. Some people with CADASIL do have trouble with language, like remembering the right or not remembering the right words to say, but how to say them in the right context. And also people with CADASIL may have trouble with what we call processing speed. So it may be difficult to hear a conversation, deal with the information, and then respond in an efficient manner. It may take longer for a person to address a situation because they really have to think a situation through very carefully. The cognitive changes that we see are related to the part of the brain that is affected by CADASIL. So if the sides of the brain, which are called the temporal lobes, are affected, we may see more language problems. If the front part of the brain is affected, we may see more problems with what we call executive function. The changes can be fast or slow because, as you know, CADASIL is associated with small strokes. And when we see the strokes, that's when we see the changes. And in some cases, CADASIL can cause dementia. And I'll talk about that in a minute. The mood changes that you may have seen that we know about are things like depression, irritability, anger, anxiety, and apathy. Of interest, apathy is probably one of the harder things for caregivers to deal with. Apathy meaning not wanting to do anything, not wanting to get off the couch, not wanting to exercise. It's very hard on families when they feel motivated and they want to help a person, but the person with CADASIL just won't engage. So apathy is very real and very difficult to contend with. Like the cognitive changes, the mood changes are related to the part of the brain that is affected by CADASIL. So just so you know, again, the changes can be fast or slow, and every family has a slightly different experience. There's no one exact path. Sometimes the cognitive and functional and mood changes progress to dementia. So a person can have vascular changes, but not necessarily dementia. So the next question would be, well, what do you mean by dementia? Well, many of you know already that dementia is an umbrella term that describes a variety of diseases and conditions that develop when nerve cells in the brain die or no longer function normally. The death or malfunction of the brain cells causes changes in a person's memory, behavior, and ability to think clearly. CADASIL causes brain changes due to small strokes in the brain, and sometimes this can lead to what we call vascular dementia. A person with CADASIL could also have a different type of dementia along with the vascular dementia. That can be pretty complicated and requires a good clinician to help sort that out. Dementia is not just something we mention in passing. It does have criteria for the diagnosis, and that criteria is changing as we speak. But the baseline criteria are these. First of all, it has to be a change in thinking, and this has to be a consistent change. The changes have to interfere with a person's ability to function either at work or at home or in their day-to-day activities. It has to be a change from their earlier abilities, and it can't be explained by other illnesses, such as an injury, pain, or a psychiatric illness. On top of the changes in thinking, in order to have a dementia diagnosis, a person has to have new difficulty learning new information. They need to have difficulty handling complex tasks, making decisions, changes in ability to communicate, or changes in personality and behavior. To qualify for to meet the criteria for dementia, they need to have the changes in thinking plus 2 of those listed below. And now I'm going to sneeze. I'm sorry. Excuse me. The cat's in the room. So many of you have heard of Alzheimer's disease, and Alzheimer's disease is a slow progressive dementia that is caused by changes due to malfunctioning proteins in the brain. Alzheimer's disease, I liken to a ball rolling down a hill. The progression is slow. The person gradually loses memory. They gradually lose function. It's progressive. That ball, darn it, just keeps rolling. Things just chronically get worse over time. CADASIL is a type of a vascular dementia, which is due to the death of brain cells due to the circulation problems caused by CADASIL. This is kind of a dramatic picture, but the general idea is the tree of circulation is affected by CADASIL and results in vascular changes. And unlike Alzheimer's disease, the changes in CADASIL tend to be what we call stepwise. So a person may go along fairly steady, doing fairly well, and then suddenly get worse, and then stabilize for a while, and then suddenly get worse. So um, yeah, oftentimes it's difficult to control, like when and why a person gets worse. I mean, you know that controlling risk factors such as not smoking, controlling blood pressure, limiting alcohol use, all of those things help protect the brain. But even in all of this, even with all of that, a person that has CADASIL is still at risk for having another stroke or another small stroke. And that's where we see the decline in function, memory, and thinking, that step down. So taken together, what we have is a person who has changes in memory and thinking. They may have changes in mood and behavior. It's difficult to know when these changes are going to occur. It would be really nice if we could predict when the changes are going to occur, but we don't know. And it's difficult as a family member to address the mood changes. And sometimes it feels like the behavior changes and the mood changes occur kind of out of the blue. So it can be very destabilizing. And all of this leads to what we call caregiver burden. Burden meaning, maybe another word would be stress, feeling kind of chronically stressed and worried. A person with caregiver who feels this kind of burden, we know that caregivers have little time for self-care. Oftentimes their sleep is affected. They oftentimes lose friends, which is mysterious and disturbing and frustrating. Especially if it's a dementia diagnosis, friends just kind of seem to be scared or step aside. There is a sense of grief, a chronic, gradually losing somebody you love contributes to what we call pre-death grief. And it's kind of an ongoing grief that's very hard on the body. And in the middle is financial strain. Financial strain is huge for families who care for somebody with a memory and cognitive trouble. Sometimes people are working and they have to quit jobs, or they have to work part-time. It can be very hard on families financially. And then caregivers are often, family members who care for somebody with cognitive change are often pretty overwhelmed. They don't have time to learn. They don't have time to sleep. And they don't often know where the resources are for support. The other thing that is different that I hear from other caregivers in a different type of dementia is they say things to me like, this is different than Alzheimer's. This is not Alzheimer's. I talk to my family or friends and they say, oh yeah, my dad had Alzheimer's, but it's not. And that's because the path is a little bit different. It's not a slow, constant decline. It's more of a stepwise decline, and it can affect younger people. So it's a difficult place to be in. So why is this important? You probably know this. Almost 22 million people in the United States provide unpaid care for somebody with dementia. Now that's about dementia. It's not specific to CADASIL, but you get the idea. Many of those who have dementia only receive unpaid care. They're not getting formal paid care. Most of the family caregivers in the United States are women. More and more men are stepping up, and we appreciate that, but most are women. And then these numbers are really interesting. This is a survey from the National Alliance for Caregiving, and they collected data on all caregivers, and they reported in their surveys that of the nationally representative sample that 36 reported high emotional stress, 17% reported high physical strain, and almost a quarter had difficulty caring for their own health. In my experience working with caregivers who care for somebody with cognitive dysfunction, I think those numbers are practically double that. I think working with somebody who has memory and cognitive changes, the stress and strain is much higher. And I think the thing that is also very challenging is about 30% of those who live with the person they're caring for feel alone. So they feel lonely even though they're living with the person that they care for. Another concern is that up to 25% of caregivers have experienced some type of verbal, physical, or sexual abuse from the person for whom they are caring. So when you hear me do lectures, you don't hear me say words like loved one, because to be quite frank, not everybody loves the person they're caring for, but because of family responsibilities, marital vows, other demands, they are taking care of that person. And about 60% feel like they didn't really have a choice. This is what they do. They're the caregiver, and that's their role. And people who feel like they didn't have a choice in assuming the caregiving role tend to have higher levels of burden and stress. The other thing that worries me is almost 90% of the caregivers in this National Alliance for Caregiving study said that their own healthcare providers didn't ask them about their health and their needs as a family caregiver. My hope is that that's starting to change and starting to shift. But if your primary care provider, whether it's a nurse practitioner, a physician associate, a doctor, doesn't know that you care for somebody with cognitive problems, please tell them, because caregiving is risky. We know that caregivers are more likely to have high blood pressure, heart disease, depression and anxiety, sleep problems, and unfortunately, cognitive problems themselves. So memory and thinking problems. And we think that the memory and thinking problems are due to chronic exposure to high stress, poor sleep, and the many factors that affect the caregivers. Just checking the time. So let's take a minute and talk about some strategies to protect caregivers. These are some things that the literature supports that helps caregivers thrive in the context of a very stressful situation. So the first thing is to seek respite. Next, engage friends and family. And the third is to learn how to address behavioral symptoms. And I'll touch on each of these in our time here. So what do we mean by respite? Well, respite is just another word for a break. Everybody needs a break. In the 1940s, the US government passed a law which established the 40-hour work week. So theoretically, you should work 40 hours a week, and you should have, 2 days a week to rest and recover. Many of the families that I work with work many, many, many more hours than 40 hours a week. And even for those that don't, they just don't get a break. So it's really important to try to figure out creative ways to get a break from being with your family member with cognitive changes. There are a couple of resources, and I'll be honest, there aren't a lot, but might as well start somewhere. The first is call your county and ask them for the caregiver support program. This is a program that is located around the United States. Different programs are stronger than others, but the caregiver support program can provide you with education and sometimes funds to support you. I live in Multnomah County in Portland, Oregon, and during COVID, for example, not only did they provide some funds for caregivers, but they also provided a food pantry because many of the caregivers were really struggling financially. Ask family members to give you a break. While your job is caring for somebody with cognitive changes, you may also need to teach other family members how to help you. They may say something like, oh, how can I help? Or I want to help, but you need to teach them how to help. And that can be a strain, but it's a good investment, not only for you to get a break, but what the research shows us is that when friends and family help other people, that it gives them a sense of being meaningful and a sense of altruism that is actually a physically healthy response and can help their health and their well-being as well. The other thing I would suggest, and I'm not that familiar with the CADASIL Consortium, so you may already have this, is support funds. For example, the Association for Frontotemporal Degeneration, which is another rare type of brain change, has a fund where caregivers can get about $500 a year for respite, so they can get those funds for their own self-care, even, like a massage, but they can also get the funds to help them, for example, to pay for a day program or memory care for their family member. Engage friends and family. Again, you're going to hear me say this over and over, but again, we know that friends and family want to help, but they need coaching, and it's good for their health to help you. And so I advise the caregivers I work with to be proactive and ready. A common response is, oh, how's your family? How's your husband? How's your mother doing? I know they have some changes. Oh, I really wish I could help. How can I help? So what you want to do is have your list ready, either on your phone or on a piece of paper, and say something like, oh, thank you. Here's my list. You can pick from it and give us a hand. And people love this because they know what to do. They could do something as simple as sending a postcard to your family member. I mean, isn't it fun to get mail these days? All the mail we get is from Costco and political ads. And sometimes a postcard can really boost a person's day. And the help list can be as complicated as mowing our lawn, vacuuming our house, bring us a casserole on Tuesday, whatever you want on your help list, write it out, take a picture of it on your phone and send it to anybody who says, gosh, I wish I could help, or let me know what I can do. They can help you. They just need to have active choices to do so. And then let's talk about behavioral symptoms. This is where most of my research is, and this is an area that I can talk for hours on. I know we have about another 10, 15 minutes, so we'll talk about it and then I'll take your questions. Again, getting back to what causes a caregiver to feel burdened. Well, it's a lot of work. There's no denying that. They also may feel isolated. They're dealing with grief. They have the financial strain. Some families have family conflict. The future is really uncertain. And one of the biggest source of burden are behavioral symptoms. So let's talk about that. What do we mean by behavior? Behaviors are tools that help us communicate. Most of the time, we use words with the behaviors to deliver a clear message. So some behaviors communicate good feelings, but others cause distress in a family. And often we're distressed because we don't understand why the behaviors are happening or how to help. All of us have behaviors, whether or not we have CADASIL or a dementia or a depression or anything. We all have behaviors. So behaviors can be good. You can tell from my colleague Nicole, she's having a great time. This is our annual brunch that we have for our research participants, and Nicole is a gregarious and outgoing person, and she's really loving this. How do I know? Well, A, she tells me, but B, you see the smile on her face, the lifted eyebrows, the dimples, the look in her body language, all tell you she's happy, she's having a good time. That's a behavior. On the other hand, some behaviors are clearly a person's distressed. You can see this person's furrowed brow, the clenched teeth, the clenched hands. On this person, you see the glum look on their face, the closed body position. Again, these are all behaviors that help us communicate. Now, behaviors and brain changes are more complicated because brain changes cause difficulty with verbal communication in many cases. So often a behavior is to do some kind of need. A person may be in pain, they may be constipated, they may be thirsty, they may be bored, but brain changes cause difficulty with understanding the problem, linking the problem to the need, stating the problem, knowing the right words, saying the right words, and communicating appropriately. So you can see communicating normally is really a very sophisticated strategy and function that many people with cognitive changes still have, but lack some. So for example, if a person with dementia is crying a lot, they may not be able to tell you why. And I've seen this in my own practice, and I'll say something like, does your family member have any trouble with pain? And the family will say something like, oh, he used to have really bad back pain, but he hasn't been complaining about it recently. Well, the reason he has not been complaining about it recently is because he lost the capability to complain about it. So sometimes just treating the pain with a couple Tylenol or other medications can help, because we are assuming that that crying is due to pain. Saying to a family member, gosh, my back hurts, do you have any of that ibuprofen that really helped? Can you go to the bathroom and get me 2 of them? That's a very sophisticated statement that some of our family members with cognitive changes can't do. So what I advise the caregivers I work with is use the ABC approach in understanding and addressing behaviors. And I'm assuming Imam will give you this PowerPoint so you can use this. But when you notice a behavior, so for example, let me think of a good one right off the top of my head. Urinating in inappropriate places. Some of the patients that I work with, they'll urinate in a potted plant in the living room. So the first idea is to try to figure out the B. Now I know it's on top of the A and C, but bear with me. The B is really the top of the pyramid. That's the most important thing. What is the behavior you want to change? And in order to understand this, you really need to describe the behavior in detail. When does it happen? What is going on? How often does it happen? What do you see? What do you hear? Does it happen at the same time every day or different days, different times at different days? Once you have a really clear description of the behavior, then you can start addressing it. We tell the participants in my research studies, excuse me, I'm just going to grab a drink, to take a step back, be the detective, be the scientist. Don't feel like you have to solve the problem right away unless it's, the person's in danger. But step back and be a little bit of an observer and see if you can figure out what's going on. Next, look at the A in our pyramid. That's called the activator. What happens before the behavior? What else is going on? So for example, our person that is urinating in a potted plant, the activator probably is that the person needs to urinate and doesn't know where the bathroom is or can't remember where the bathroom is. So there are probably clues that that person needs to use the toilet, but we may not have noticed them before until we really looked at the behavior. And then look at the consequences, what happens after the behavior. And sometimes the consequences are for the person with the cognitive changes. So feeling embarrassed, feeling upset, feeling relieved because they finally could pee. And then there's also consequences for the family, right? Feeling frustrated, mad, I have to clean it up again. It smells, it's icky. So there's consequences all over the place. And the point of understanding the consequences is sometimes it helps inform the activators. And so then once you know what the behavior is, what the activator is, and what the consequences are, write all of that down. So you have an idea of what you're dealing with. And then add to that list, brainstorm some ideas about what would help. This is really important, and this is where it can be helpful to have friends and family chime in and give you suggestions. So, for example, in our person who urinates in a potted plant in the living room, may need to be taken to the toilet every couple of hours so that they don't feel a need to pee in the plant. Or there may need to be signs on the bathroom door that says men's room, or maybe there needs to be a sign that says, yes, we're open. So the person would be curious and go into the bathroom. It may be that, we know that some people with dementia have a little trouble with depth perception, and it may involve putting a black toilet seat on a white toilet so they can see the toilet and they can see where to pee. These are all brainstorm ideas. I don't know what would work for that family, but if we don't brainstorm, we can't think of ideas or ways to help. Once you brainstorm the idea, then write it down, make a plan, and then try it. Many times the plan isn't going to work right off the bat. You have to go back, try it again, think of something else, get somebody else involved. For example, maybe your family member needs to see a urologist, or maybe you need a physical therapist to come to your home and teach you about safety, ambulation, or maybe an occupational therapist who can help you revise the bathroom so that it's easier to see where it is and use it. If a person has a diagnosis of dementia, they are eligible for home care services, even though they are not technically homebound. So a person can get home care services if they're homebound, but the newer rules allow us to order home care services such as occupational therapy, physical therapy, and nursing care if the person has a diagnosis of dementia. So make sure to ask your primary care provider for that if you think that might help. And sometimes we don't know if it's going to help, but it's worth exploring. And Medicare does pay for that. And most insurances do too. So that's the bit about behaviors. We can talk about that a little bit more with your Q&A. I do have some resources for you. This is the link to the Family Caregiver Alliance. That is a national organization, and I realize this is a national audience. They have some really great classes and resources and ways of connecting with others. The Alzheimer's Association has classes on communication, legal planning, and just the stages of dementia. So I do recommend that for information. I don't know if there's a CADASIL support group, but if there isn't, it sounds like that might not be a bad idea to get started. One more resource for you, and it's not for everybody, so I apologize, but we do have the Stellar study that is for families who take care of somebody with dementia. So it's possible that your family member may have CADASIL but not have dementia. This is only for people with dementia, and this is for people who live in Oregon, Washington, and Idaho. I'm sorry, we have been funded by the private family who wants us to do this work, and those are the states they want us to use. But if you're interested, please give us a call. We'd love to hear from you. So now let's take some questions. I'm going to stop sharing, and let's see what we can do here. See if we can help you at all. One of the questions that came in earlier was to describe the stages of dementia. In my world, we use the mild, moderate, and severe. There are other ways to stage dementia. There are the 7 stages of dementia. There's what we call the clinical dementia rating scale that stages it. So it can be a bit confusing. But essentially, the mild phases are when, a person can still communicate with you, can express their wishes, can take care of most of their bodily needs, and function somewhat normally in life. They do need some support. They do need help. Otherwise, they wouldn't have a diagnosis of dementia. But they are more capable. In the moderate phases, a person with dementia may need more help with things like needed to be reminded to take a shower or need more help with communication. At the moderate stages, we may see more behavioral symptoms such as depression, anxiety, agitation. And that the moderate stages are particularly challenging because the person is at the core, the essence of themselves, and families really have a need to respect their agency, but are challenged by the changes they see in their family member. And then the severe stages are when a person can no longer really take care of themselves at all. They need to be clean. They need to be washed and fed. They need help with toileting. And in the severe stages, that's where we like to think about hospice to make sure that families have that resource and that the hospice services that are paid for by insurance and Medicare and provide support as a person gets closer to the end of life. All right, let me pull up some of your questions and see if I can help you. Yes, so can CADASIL occur in conjunction with Alzheimer's disease and primary progressive aphasia? Yes, it can. The problems we have with the dementias is we make a lot of our diagnostic diagnoses based on the history. It's getting easier now because we do have more blood tests and brain tests, so we can make a better diagnosis. And I believe in CADASIL, there's also a genetic testing that you can do. That said, it is possible to have all of that together. And the primary progressive aphasia could be caused by Alzheimer's disease. It's also possible that CADASIL could cause a type of dementia that's in the same class as PPA, which is a frontotemporal type dementia, because the CADASIL could affect the front part of the brain. But yeah, unfortunately, the most common type of dementia is a mixed dementia. So vascular dementia with an Alzheimer's, Lewy body with an Alzheimer's. So again, the dementia that comes with CADASIL is typically vascular, but you could also have Alzheimer's. Oh, what kind of activities can we get our loved one with advanced CADASIL involved in? That's a really tricky one because obviously I don't know your family member, but whatever you think is safe and meaningful. And this is where the ABC planning can be really helpful because you can brainstorm with your family about what we call pleasant events. So what are the little things that can make your life and your family member's life a little bit more pleasant? So it could be anything from, something complicated like going to a movie to something fairly simple like a hand massage with lotion, or eating ice cream together, or taking a stroll in the garden. This is where other family members can be very helpful, because when you're carrying somebody with advanced disease, you kind of get tunnel vision, and it can be very helpful to have another person come in and say, oh, well, remember when he was a teenager, he used to love, rock and roll. So you would go and find a list of music that is back from when the person was a teenager. And that can be super fun. And a lot of families have found some real joy with music. Oh gosh, do you have any advice for caregivers who are managing incontinence and how to keep the mess minimal? That's tough work. Yes, I do. I would, not knowing your situation, I would investigate. There's an organization, it's called the National Association for Continence, and NAFC, and they have a lot of great resources. For example, they have information on products, and they have information on how to address incontinence issues. So again, it's called the National Association for Continence, and that is probably the most comprehensive resource I can give you. But again, the incontinence, you might want to think about ABC planning. Is it possible, for example, to help a person to the bathroom every couple of hours so that they're not as incontinent? It's an art, and I'm sorry I don't have the best answers for you, but that's something to think about. Yes, I struggle to communicate with my loved one because they're mostly nonverbal. Do you have advice for other ways of communication? Yeah, Layla, if you haven't had the chance yet to meet with a speech and language pathologist, again, a speech and language pathologist, I would encourage you to ask your neurologist or your clinician to refer your family member to a speech and language pathologist that specializes in dementia and what we call augmented communication. So not all speech and language pathologists do, but the ones that do, they are priceless, and they can help you do things like develop memory books that you can go through together, or even day-to-day functional books, like maybe taking a picture of your favorite restaurant or taking a picture of something that makes you happy and putting that in a photo book to help with communication. There are also applications on your phone, on your iPhone. I don't know of any right off the top of my head, but I imagine if you look under in your phone under augmented, AUGMENTED, augmented communication, you'll probably find some strategies. And for the family living with primary progressive aphasia, I would also highly recommend that you talk to a speech and language pathologist. And then the other piece of information I can give you, if you don't mind me just hunting around a little bit, the Northwestern University has research for people with primary progressive aphasia. Let me see if I can find that. Well, I can get back to you, Iman, with that information. And oh, here it is. Okay. Give me 1 minute. I apologize. I don't have it. I'll get back to you, Mom, with that information. My sister with CADASIL dementia sleeps a lot most of the day. Do you know the reason why this is happening? Boy, sleep is really challenging. And when you say she's sleeping a lot most of the day, I'm wondering if she's up a lot at night. Sometimes people with dementia, no matter what type, get their days and nights mixed up, and that can be really tricky. The other thing I've seen is families, people with dementia sometimes just sleep a lot, even night and day. And I don't know the answer to why that's happening. I can only guess, but I do think certainly the brain changes do affect our brains and how we understand and deal with sleep. If it's something that you would like to address, certainly you can ask for a referral to a sleep specialist to evaluate it. The other thing that we do recommend in our clinic is making sure that the person with dementia, and honestly, all of us, are exposed to morning bright light in the day. Now, I live in Oregon and it's pouring rain right now, so sometimes morning bright light is a little bit elusive, but it does change the internal brain and can help a person with their sleep issues. Let me just look through this one real quick. Yeah. Yeah, so Doug is talking about issues around incontinence, both urinary and bowel incontinence. And there are a number of products that can be helpful. Sometimes the medications, I'm glad to see it's the Myrbetriq and not an older type of medication for incontinence. But sometimes those medications just don't work in the context of dementia. And so that's where, the frequent trips to the toilet to help them eliminate on a regular basis can be helpful. And again, the National Association for Continence may be able to help you. There are some newer devices that can alert families when there's incontinence. There's all kinds of devices and padding and information out there. So again, try the National Association for Continence. Another issue, yeah, sometimes her state of mind is cloudy, unable to talk, and other times she's okay. That's tough. We do see that in different types of dementia, which we call vacillating awareness. Sometimes they're really on their game, sometimes they're not. And I don't have any great explanations, but I do know that it's a real phenomenon. What's frustrating is that if you could control it, if you could know when the time that she was on or off, you would be able to capitalize on it. But I bet you probably don't know which day is going to be a good day and which is going to be a bad day. So the main advice I would give you on that one is make sure that you also take care of yourself. Because it can be very stressful to live with somebody where you're not quite sure what they're going to be like that day. And I'm going to give you guys the link to this. Okay, it's Imam, if you wouldn't mind putting this in the chat box, it's just NAFC.org, the National Association for Continence, NAFC.org. When you go to that website, you'll see the different conditions, management, and even has access to specialists that can help you.
Yes, I put the link in the chat box.
Oh, thank you. Oh, Ryan asks, what's the youngest known individual who's shown signs of CADASIL? Ryan, I don't know the answer to that. I'm very sorry. Maybe Iman or other people know.
I will type out my answer from a research perspective, but I'm not a clinician, so I can't give a very detailed answer.
Okay, yeah. Doug, your comment that she ends up removing her Depends when in bed. One strategy, and it's not a very popular one, but it is a strategy, and it's clothing that has the openings on the back instead of the front, so they can't get to their diapered area. In some cases, it's considered a restraint, so some facilities don't allow it, but it is something that sometimes can help. And so if you do a search online for clothing for incontinence, they may have that on there. Again, the clothing is such that the openings are in the back, so zippered or buttoned. This is also helpful for people who can inappropriately touch themselves. We do see that with people with dementia too. Yeah, I like this. Do persons with dementia have good days and bad days, and does their awareness change through the day? Yes, they do. It kind of depends on the type of dementia they have. I would imagine with CADASIL that might be the case. The other kind of dementia that does this is it's called Lewy body. It's Lewy, and then the next word is body, BODY. And those good and bad days, it's quite pronounced in Lewy body dementia. And again, there isn't any real cure for it, but for some families, it's helpful to know that yes, that does happen. Again, it would be nice to have some control over it so you would know what are the good days and bad days, but unfortunately we don't. Yes, excellent. Gosh, you have so many good questions. How do we find options for end of life when the dementia is very advanced? Should we plan for that now? Yes, absolutely. So if you have not yet talked with your clinician about advanced care planning, please do. Most states have, if you go to your state government's website, they have living wills or advanced care plan documents that you can fill out. The other form that we have in Oregon and in many states is called the POLST. It stands for POLST. That's Providers Orders for Life-Sustaining Treatment. What that does is it tells any treating clinician or emergency personnel what your family members' wishes are should they no longer have a heartbeat or be breathing. Do you allow a natural death, or do you want them to do CPR? If a person has advanced dementia, CPR is probably not going to be successful, and if it is, it's certainly going to make the dementia worse. So making sure that you have your POST form filled out. If your state doesn't have that, definitely your advance directive. And then it's personally, I don't think it's ever too late to talk with your primary care doc or your neurologist or your nurse practitioner about hospice. Hospice is a fabulous benefit that is available to anybody with insurance, unfortunately. But it provides medical care at end of life, and it pays for the medications, it pays for support services, it pays for volunteers to come and be with your family member. Many people with dementia, their families get hospice 2 or 3 days before the death, which is far too short. You deserve at least 6 months. And if your doctor or your clinician signs your family member up for hospice, what they're saying is they think that your family member has about 6 more months to live. However, if your family member doesn't die in that 6-month time period, it's okay. You just renew the hospice services. It's not a hard, fast rule that they have to die within 6 months. So I encourage the families that I work with is to call a hospice up. Just call one up in your neighborhood and say, hey, can you come out and assess my family member? And many times they will, and they'll give you some information on how to prepare for that future inevitability. You guys have really good questions. How do you recommend dealing with aggressiveness and irritation? That's such a hard one. The irritation, I think, is almost harder than the aggressiveness because irritation is so elusive. I do recommend taking classes through the National Caregivers Alliance, and certainly thinking about taking a minute to look through my slides and look at the ABCs. Aggressiveness is another symptom that's often caused by some type of unmet need. Are they hungry? Are they in pain? Can you tell what happens right before the aggression occurs? Or can you tell what happens right before somebody's irritated? It may be that they're hungry. It may be as simple as giving them a banana. I don't know. I don't know your family, but using a systematic approach can be very helpful. What activities do you recommend for caregivers I understand what you're saying. What do you recommend for caregivers to reduce your stress level when you're home providing care? Because sometimes I'm worried to leave my home and have to leave them alone. Your worries are valid and important, and you're right. Unfortunately, if a person is unable to take care of themselves, you can't leave them alone. The way I measure that is, would they be able to call 911 on their own if there was an emergency? And if they can't, they probably shouldn't be left alone. So what I do recommend is trying to find some type of online support group. That can be really helpful just to talk to other people in your situation. The Alzheimer's Association does have that. The other thing that you can do are thinking about meditation apps on your phone can be really helpful. And then what we call mindfulness exercises that help you tune in to what's going on for you. The other thing that I've noticed over the course of my career is think about the things in your life that were fulfilling and meaningful for you when you were a little bit younger. So for example, a lot of people when they were younger used to go to church a lot or had a spiritual life. Tap back into that, or find that instrument that you have in the closet and start playing your flute again. Or think about if you can't get out and exercise, think about getting a stationary bike or a treadmill from Craigslist or a used bike, just so that you can get some physical exercise. All of us, as we age, all of us are at risk for developing dementia because the number one risk for dementia is age. What we know about preventing dementia is eating a Mediterranean diet, and exercise up to 150 minutes a week where you break a sweat. We know that those strategies can be helpful in keeping your brain healthy. So if you don't have some kind of exercise, I would highly recommend that. Yep. Yeah, Roland, I hear what you're saying. What I have learned is that people with CADASIL start seeing symptoms early in their 30s, but it's very vague and maybe misdiagnosed. Um, this is also very common in families who live with frontotemporal dementia, that it's so hard to get a diagnosis because it's rare, and clinicians don't know what to look for, and they don't know that they need to look for it, and it can be a very difficult and frustrating journey. And CADASIL does affect people in their 30s, so definitely worth looking into. Yeah. Doug, the physician-assisted suicide is a tricky one. In Oregon, we do have it, but a person has to be cognitively normal, which is very hard for my patients with dementia. It's definitely an issue that many of my patients talk about, and that's something that unfortunately we're going to have to deal with at the policy level. I'm sorry I don't have good answers for you on that. In Oregon and probably nationally, there was an organization called Compassionate Choices that talks about voluntary cessation of eating and drinking. But then that can be tricky. But people who do that, when they get to a certain point, they can't have hospice services. So again, the name of that group is called Compassion and Choices. So that might be worth looking into. I see we're at the top of our hour. I want to take a minute and thank you for carving time out of your day to listen to me. I hope it was somewhat helpful. Please let Iman and the team know if there was something we could do differently to make this better for you. And I hope that this autumn is unusually easy and pleasant for you. And thank you for being a caregiver. It's very important that we have people like you who watch out for people who need you.
Thank you, Dr. Lindauer, for your presentation. If anyone has any additional questions that we didn't get to answer, feel free to email them to me, and I will also include Dr. Lindauer's email in our follow-up email. And thank you, everyone, for joining us this evening. Have a nice night.
Bye.